Welcome to our podcast, Health Dialogues Bridging the Voices, with your host, Mamelo. Today, we are honored to be interviewing a clinical researcher who has been working in the field of HIV in Lesotho for several years. Lesotho is one of the countries that have achieved the 1990 goals, where 95% of people living with HIV are aware of their status. 94% of those who are aware of that status are on antiretroviral treatment. 99% of those who are on ART are virally suppressed. Looking at the statistics as per the Lesotho Demographic Health Survey of 2023-2024, more women are knowledgeable about PrEP as compared to males, with the staggering results of 95 to 58%. With regards to also the statistics of people knowing that ART can treat HIV, women are more knowledgeable with 95% as compared to 85% in relation to men. Moving on to the educational awareness of HIV. HIV awareness has increased in the people that have most secondary schools as compared to those who have primary education. Welcome and thank you for joining us, Elaine Jammers. Can you introduce yourself in the work that you have done in Lesotho?
Thank you very much for having me on your podcast. My name is Ale Amstutz. I'm a clinician researcher from Switzerland. I have a PhD in clinical research, and for my PhD, I was living in Lesotho for 4 years, where I did a PhD around HIV together with many different partners from Lesotho and Switzerland. At the moment, I'm on a postdoc position, working on different projects with several universities, but I'm back in Switzerland. There were 4 different projects. Project number 1 was a project about the optimal second-line treatment for people living with HIV and having low-level viremia, so meaning having just a few copies of the virus in the blood on treatment, not fully suppressed, but also not fully unsuppressed. And we were looking at different treatment combinations that would help such people to resuppress the virus. So that was a project at different HIV clinics in Lesotho, and it was a randomized clinical trial. That was number 1. Then number 2 was a project with the village health workers, so the famous village health worker program in Lesotho. So these are lay people from the community, elected by the community and serving their community. And what we tried is to collaborate with them and train them on the HIV self-test, the oral HIV self-test. So the very simple to use test. And we at the time did many door-to-door campaigns for offering different services. This was all in collaboration with the Minister of Health and Solidamet, an NGO active in Lesotho. And during this time, we did lots of these household door-to-door campaigns. And one idea was to do these campaigns together with the village health worker, leaving self-tests in the household for people to use after we have left, and follow up these self-tests by the village health workers who live there, and they then doing all the follow-up, linking people to the clinic, offering post-test counseling, and so on. So that was the second big project. Then the third project was connected to that one, and it was about going a step further and also training and engaging these village health workers to follow up treatments, because as you know, the terrain is quite difficult and access to the clinics is not that easy. So we thought maybe it's a good idea that village health workers can also offer to deliver the treatment for people who want that. That was project number 3, and then project number 4 was a project with young people living with HIV, um, and a youth organization where we developed a youth model of care together with an app, so that peer educators at the clinics, they can have this app to organize the services for their peers, and to make it easier for them to navigate all the different services, to always have a peer who is responsive, who is connected through the app with them, and basically to help them along the journey of living with HIV. And that 4th project was also a randomized trial. So actually, all the 4 were randomized trials. The 2 with the village of workers, these 2 trials were very big, in more than 50 villages. Yes, while the last one was one that we did at 20 health facilities across Leribe, Buthabute, Mochotlang. So some of them a bit smaller, some of them a bit bigger, but all around HIV and to improve the HIV care cascade.
In your introduction, you have mentioned working with community health workers. I'm curious to know, how was the first engagement like? Were they willing to participate in this program or not? Did you see any resistance from them?
Yes, that's an important aspect, and we try to engage the village health workers as best as possible. It's not the first time that we collaborated with the village health workers. In fact, the local NGO Solidamed has always collaborated with village health workers. They're very close to them. They're close to the health facilities, who in turn supervise these village health workers. So it's a whole system we are active in already since quite a while. We also made sure that we have the village authorities informed and engaged. So not only the village health workers, but also the village chiefs. So that's kind of a separate system, government system in Lesotho, whereby a village chief oversees her or his village or his area, and then there's a council where they all meet and discuss topics. And we would, for example, go to such councils. There are different ones for the different areas, and we would go to this council and explain the project and have discussions, and eventually also get approval from them to run this study in their districts. So not only from the Minister of Health, ethical board, but also from the community board. And that, I think, was very important as an entry point. And then again, it's many of these village health workers we already knew just from collaborating with them. For example, they do a lot of other services as well, right? So in maternal care, tracing, in HIV care. So if someone doesn't come back to the clinic for their treatment follow-up, then often village health workers are asked to look for this person. And they have monthly meetings at the clinic. So our team in Lesotho at Solidamed, they know these village health workers quite well from these monthly meetings. Yes, but as you say, I think that's a very important aspect to engage with them. And the difficulty there maybe is also a bit that they some of them rotate. It's not a necessarily a very stable system. Some change, some find work, they go away. Some leave, so you constantly have to engage with that community and keep in touch with village health workers. I think it was quite well received. We did invest in a lot of training at the beginning, so going from health center to health center, and having specific meetings with all the village health workers, and training them on specific aspects of HIV care. They knew already quite a bit. It's not, I mean, they do some work in HIV already, but for example, the project about antiretroviral therapy delivery, that needed definitely a bit more training. Yes, no, it was actually well received. Of course, not everyone in the villages likes their village health workers to be more engaged in their own care, and that's why it was also always a choice that a person could choose if they want to have a follow-up through the village health workers, and some clearly did not want, and some really liked this idea because it was convenient for them. And I think that's important in such a project, that you keep the option for choice open.
You touched on the critical information on adolescent model of care. And I know now that social media plays an important part in disseminating HIV information, whether it's misinformation or accurate information. From your own point of view, do you feel like this model has increased the number of self-testing and a number of people having more accurate information about HIV self-testing among adolescents?
Right. So what the idea was, that peer educators are at the center of the healthcare experience for their peers. So if a young person living with HIV comes to health center, what is a bit the issue, that often there is the older nurse who is very competent, who is doing a good job, but it's just not a young person who might fully understand what's happening in a young person's life, and might have their own perceptions, and we know that it's a bit an issue sometimes with this interaction between the older nurses and the young person coming to the clinic. So our idea is that there's a peer educator responsible at each clinic for basically every young person walking into the health center, welcoming them and kind of offering them the navigator or the entry point for their HIV care at their health center. That was really the aim, and we collaborated for that project with Setebale. That's another NGO in Lesotho. They have a lot of peer educators, very well trained, and well educated in dealing with lots of issues around HIV. Many of them live with HIV themselves, and the idea was to empower these peer educators at the clinic to navigate care for their peers. And for that, they needed an app, because it gets a bit complicated, right? If they have to, if they can offer their peers a lot of different services, so be it, counseling for sexual reproductive health topics, be it offering them, for example, phone calls or SMS to encourage young people to keep taking their treatments, or they offered lots of different options for their peers, and they typed in all these different service options into the app to keep track what the young person was choosing, and to also document then these services that the young person was choosing. So, for example, they could choose from receiving different SMS with different messages, encouraging messages, for example. They could choose then the frequency when they want to receive this SMS. They could choose SMS that reminds them to take the medication every day, or they could choose SMS to remind them that it's time to come back to the clinic for a refill. They could choose SMS that directly translated the result of their viral load measurement into an SMS. So they're kind of saying, if you have half yearly your viral load measurement to check if the virus is suppressed in the blood, then the app would send them automatically a thumbs up, or saying, you maybe should come, we have to discuss, kind of message to their phones. So all of different things around the SMS, but also they could, for example, choose to get their refill, so their refill of antiretroviral therapy, through the peer educator instead through the nurse, so that they would at the clinic be in a room with the peer educator. The prescription, of course, comes from the nurse, but it's actually the peer educator who talks to them and provides them the medication. Some even managed to organize getting refill at home, so that peer educators would visit them if they wanted that, and bring them the antiretroviral treatment to their homes. So lots of different things they could choose from. Yeah, quite a big model of care we offered, and that's why they had this Pebra app, an app we developed so that everyone could keep track of the needs and choices that these young people individually took. In terms of outcome, so we had it was a very, very well received project also by the clinics. They really appreciated the peer educators who also took away some work from them. They felt that they played a big part at the clinic, bringing a bit more youth-friendly services to the health center. So the peer educators did really a great job and they were highly appreciated. Um, the young people, the participants who took part in the study, we also got a lot of very good feedback. Satisfaction was very high. In terms of clinical outcomes and more these care outcomes, we assessed them. This was part of a randomized trial. We could show that we had a bit better engagement in care, meaning young people from the start, they stayed at the same clinic and engaged in care a bit better in the group that offered this model of care than the other group. In terms of viral load or viral suppression, we could not show a significantly better outcome in the intervention group, but that's also sometimes a bit hard to show with this kind of trials. But there we could not show a difference. Yes, exactly, and that was probably the main results. We also had more of an implementation process that was developed alongside the project to interview young people, to interview peer educators who took part in the project, just to gather their views, and that's a separate project and published separately.
I know you have mentioned that some of the innovative challenges that you have done is, or you have implemented, was SMS based to try to reach more people with HIV information and self testing. I'm curious to know, and I really do understand that through this project, you have managed to reach more than 20 clinics in the country, which is quite remarkable. Thank you for your services. I'm curious to know whether you have seen differences in engagements between rural and urban settings.
That was only for the peer educators, not for the participants. And peer educators, we only had 20, so 20 clinics and one peer educator per clinic. And each peer educator had then an app on a tablet they received, and that's how they managed to coordinate the services. And each peer educator had maybe around 30 or so young people they navigated or coordinated the services for. The participants and the young people accessing the services, they didn't need to have a smartphone or the app or anything. And most of the communication actually then went through SMS or WhatsApp. This project was actually all in the rural, so it was all in the rural areas. We didn't really have the big towns in there, so we didn't have Butabute town or Mochodlong town in the sample. The idea was exactly to go out to areas where access is harder.
Thank you for the clarification that the SMS-based initiative was solely centered around rural services, and I think that was a good move to centralize it around rural settings, because looking at the statistics, there's areas where there's lack of services as compared to the urban areas. Based on a follow-up question with regards to that, what are the most barriers in these areas, the rural settings or hard to reach areas in Lesotho? What would you say are the biggest barriers or challenges in accessing HIV services?
I mean, it, clearly, th- clearly there is an issue with, with the whole infrastructure and the setting and the terrain. Some of these villages, they grew out of a cattle post, really in a remote area, and people walk for hours to reach the next or their designated health center. Some on horses, some walking. So the infrastructure to reach services is definitely one of the factors. Having said that, I don't think that's the only issue. And nowadays there are outreaches and people have ways to access services and maybe with mobile technology this could become also a bit an opportunity, even though many people in these rural areas still very much rely on Moschocha and just the simple phone and not the smartphone. Um, but there's this there's certainly also a bit of difference in culture and um, between the rural and the urban areas in terms of education, maybe in terms of stigma. So I think that there are other aspects to rural versus urban than just being far away from a clinic.
In conclusion, in your own opinion, what would you say could be an innovative ideas to try to reduce the number of reinfections in Lesotho, and not only just the idea of reinfections, but also to try and reach the 95, 95, 95 goals?
Well, I think there are many different ones, and we could brainstorm quite a bit. Not sure I have a good summary of innovative solutions, but yeah, I think bringing services closer to to where people live and how people live is certainly a recipe. And with this, I'm not just saying the village health worker in the community, because that's maybe not the model for everyone, right? Maybe not everyone wants their older village health worker in the village to be the main focal person for their health. And I'm especially thinking about the youth. Maybe that's not the model they envisage, or they care most. So maybe other innovative spaces for young people are needed, be it, at, let's say, a hair salon, for example, or be it more than going online, so into more social media and forum and using the smartphone among young people to create a space where they feel listened to and engaged and can access services in such a way. And of course, with technology and mHealth improving in Lesotho as well, that's definitely an area to watch. Then, of course, there are lots of new innovative products coming onto the market. For example, thinking about the long-acting injectables, and Lesotho will be one of the first ones implementing these products of maybe already next year, 2026, maybe some of these products, especially lenacapavir, might be on the horizon in Lesotho, and that will be interesting to watch. Who will want these services, how we bring these innovative and very promising tools to the people most in need. So I think there are some promising tools on the horizon that we need to watch. Yes, and then I think in the healthcare system itself, health policy wise, there could also be some more innovative solutions implemented, be it telemedicine, be it with more outreach, be it with services offered in a different way. So I think we have a lot of things to brainstorm and discuss about how to improve the situation.
Thank you for joining us today. It has been one of the most engaging conversations today and really informative about the ongoing projects to reduce the number of HIV reinfections in Lesotho, and I love how different stakeholders are implementing various projects to try to increase HIV testing among adolescents and other vulnerable groups. Thank you so much.
Thank you very much.